Hello, my name is Andrew Monti, the current president of the Pharmacogenomics Global Research Network. As part of NHGRI's Provider Education Week in Genomics, we're pleased to be able to offer a Best Practices in Pharmacogenomics Implementation seminar given by Drs. Ellen Keeley and Dr. Sander Binns. These two will talk about implementation in cardiology and oncology. If you're interested in this and other content through the PGRN, please join us at pgrn.org. Welcome to our best practices seminar. We're really excited to offer this content today. And today we'll be recording this talk and it'll be available on the PGRN website. So of course, thank you for our sponsors whom without their support, these talks would not be possible. So thank you to Color, Regeneron, Merck, and 23andMe. I want a couple of brief announcements. Our PGRN fall meeting is scheduled for a satellite at ASHG on October 18th. We now have a wonderful topic for that. It'll be advancements in global pharmacogenomics through collaboration. Abstract submission will begin on June 1st and will be open until August 2nd. So look for those announcements. July is our one-year anniversary, so think about renewing your dues in the next month or so, and we, of course, will send you some emails on that. Upcoming RIPS sections, our early career version will be on Friday the 28th, and here are our two wonderful speakers, so we're really excited for this session as well. These sessions have been just really good, and it's been great to see our junior researchers really putting together some wonderful talks and some wonderful science. So now I'm going to turn things over to Dr. Ron Van Schaik, who will introduce our speakers for today.
Yeah, thank you so much, Andrew. It's a real pleasure to be here and to welcome you all to today's PGRN seminar. We have two excellent speakers here, and I would like to say good morning to everybody. If I saw it was 8 Pacific time, 11 Eastern time. I can tell you it's 5 p.m. Amsterdam time. So for us here, for Sander and me, it's ready to go into the weekend. The two speakers today will share their disease-specific pharmacogenetic implementation, their best practices. And I'm very happy to have these two speakers here because I think they have an excellent story to tell. And we'd like to start off with Ellen Keeley, MD of the Division of Cardiovascular Medicine, University of Florida. Dr. Keeley's interest is the primary percutaneous coronary intervention for acute ST elevation myocardial infarction. And she has an impressive 104 publications, among which several are in Lancet and New England Journal of Medicine. So without further ado, I would like to invite Ellen to give her talk about CYP2C19 testing in post-myocardial events.
All right, my name is Ellen Keeley. I'm an interventional cardiologist at the University of Florida, and the hospital that is associated with the University of Florida in Gainesville is called Shands Hospital. And I'd like to talk a little bit about my experience testing for the CYP2C19 SNP in our clinic, which we call the post-myocardial infarction clinic. But first, I'd like to just go over a little bit of background data from previously published registries. This is data from the REAL-TICA registry. And this is data from about 614 patients who had an acute coronary syndrome and underwent coronary stenting. And what the investigators found is about almost a quarter of the patients stopped their ticagrelor. So they were supposed to be on dual antiplatelet therapy for at least a year, but they stopped their ticagrelor prematurely. And there's a host of different reasons why they would stop their medication, whether it be side effects or costs. But what the investigators did find is that, unfortunately, only about 50% of the patients who stopped their ticagrelor for whatever reason, they did not have another medication such as clopidogrel or prasugrel prescribed to them. These patients who stopped their medication prematurely had significantly increased adverse events. So that's kind of patient specific. Well, what about hospital specific? And this is data from about 20,000 admissions using our Medicare database. And what you can see, the medications that are standard medications after an acute myocardial infarction that we prescribe, beta blockers, ACE inhibitors, or angiotensin receptor blockers, statins, and thiopyridines. As you can see that there's a big variation across different hospitals at 90 days to see how many hospitals and how many patients still had the proportion of days covered with their medications. And the important thing about that is that not only is there variation according to the hospital, but the hospitals that were in the lowest quartile of 90-day prescriptions for these needed medications, those hospitals had the worst outcomes, including increased risk of death or readmission. So this is an important problem. Now, particularly here in the United States, I would say that this is data coming from the Paris registry, which looked at reasons and patterns of non-adherence to medications, particularly to thiopyridines, according to age and previous heart attack, whether or not they were also on other anticoagulation, and if they had a stent placed in their left anterior descending artery or not. But particularly here, which I think is interesting, the region, whether there were patients in the United States or in Europe. And you can see the patterns. There's, of course, patients that need to stop their dual antiplatelet therapy, primarily due to bleeding issues, and we're always concerned about that. But I think what's really concerning in this graph is showing that some of the patients in the United States had the very much increased risk or odds of stopping their dual antiplatelet therapy just because of non-compliance compared to patients in Europe. So this is very significant, and it's what kind of a nice backdrop to what I'm going to present from our hospital at Shands Hospital. So Shands Hospital is a large hospital. It's a safety net hospital. It cares for large group of patients, many of which are vulnerable. We see a lot of medication non-adherence, and it's multifactorial in nature. But for the most part, most of the patients cannot afford the one particular medication I'm going to focus on today, which is ticagrelor, only because this is a medication that the American College of Cardiology, American Heart Association recommends as kind of top-line medication for patients who've had a acute coronary syndrome, whether or not they've had percutaneous coronary intervention. They recommend that patients to be on that plus a baby aspirin. The problem with ticagrelor for our patients in this hospital is that it's expensive. And we do have a patient assistance program, but not all patients are eligible. There's a lot of paperwork that the patient has to go through in order to see if they're eligible for that program. And that's difficult for them many times to go through the red tape to fill out this paperwork. And also the patients are, many of the times, even with a small copay, they can't afford it. So we have a very, for the most part, vulnerable population here. We started a clinic that focuses on seeing patients who have been just recently discharged from the hospital after having a myocardial infarction, and we call it the post-MI clinic. In that clinic, which is multidisciplinary, the patient sees cardiology. They also see a pharmacist, which reviews all their medications and reviews all their possible interactions with medications and answers questions about their medications. And then the patient also sees an exercise physiologist associated with our cardiac rehab program. We have seen, for the most part, on a weekly basis, that many patients come in and they say that they could not afford their ticagrelor medication, and so therefore they're not on dual antiplatelet therapy, and they just had a fresh stent in their artery. So that's very dangerous. That increases their risk of subacute stent thrombosis. We also see patients who, and we're seeing this more and more, patients who have other reasons to be on anticoagulation, such as being on apixaban or Coumadin, because they have atrial fibrillation. So they have atrial fibrillation and they came in with an acute coronary syndrome, and now they're discharged home on clopidogrel and no baby aspirin, but their anticoagulation medicine. And so really they're on just single antiplatelet medication. We do that a lot now and not put them on the triple therapy, including the baby aspirin, so that we can decrease the risk of bleeding. However, that concerns me sometimes when they're on clopidogrel because of the CYP2C19 concept, which we'll go over here in a second. So what we decided to do is, because our patient population was fairly vulnerable from many reasons, and we have a very strong College of Pharmacy here at Shands, University of Florida, what we decided to do is to do kind of a pilot study and test particular patients in our post-MI clinic for the CYP2C19 genetic testing. We use little buccal swabs, and we do it in the clinic itself. We send it off, and the result is back within several days. And we particularly test patients who either cannot afford the ticagrelor or do not cannot be enrolled into the assistance program, or if patients have side effects to the ticagrelor. This medication leads to a lot of people having the shortness of breath, and I think it's fairly more common than the package insert would say, so to speak. So we do see a lot of patients who become very short of breath, and they really can't tolerate that medication. So what we've been doing is testing them in clinic, and then within several days, when the result comes back, we're able to determine whether or not they are a good or intermediate or poor responder to clopidogrel, which can be helpful. Because if they are a good or normal responder to clopidogrel, then we feel as though we can safely de-escalate them from the ticagrelor medicine to the clopidogrel medicine, which is very much more affordable here for the patients. And then also there is prasugrel, which is also generic here. It's not as cheap as the clopidogrel, but it's much more reasonable, much cheaper than the ticagrelor. So we have another, if they're not a good responder, then we have another agent to choose. So what we've done so far, we've tested about 166 patients so far in our clinic, and we've found that about a third of them are actually intermediate or poor responders to clopidogrel. And which is about exactly what is stated to be in the population in general, about a third of patients. We have switched patients from one medication to another in about 15% of the time. It's very interesting because we had two patients who were discharged on dual antiplatelet therapy with clopidogrel because of issues that they couldn't afford it in the hospital, and they were already sent home with that medication instead of the ticagrelor. And these two patients ended up with subacute stent thrombosis, and when they were tested in clinic, we realized that they were both intermediate responders to clopidogrel, which doesn't prove why they had subacute stent thrombosis, but it certainly is concerning that if these patients maybe were tested up front, we would have known that clopidogrel probably is not the best choice in these patients. So in summary, at least in our hospital, the cost of ticagrelor is a major problem, and it's considered the choice from the ACC/AHA guidelines, and so most patients are discharged on it only to find out that they cannot afford it when they go to the drugstore. Our post-MI clinic has been able to catch many of these patients and test them using the CYP2C19 genetic testing, and in a lot of ways kind of more safely de-escalate a lot of the patients down from ticagrelor to prasugrel or clopidogrel, such that they can stay on their dual antiplatelet therapy, which is what they need to be doing, and be compliant with it because of cost issues. And here, the testing, the testing is done and kind of packaged in with the cost of the overall hospitalization. The other thing that I'd like to bring up is that it's not standard of care. The ACC/AHA guidelines tells us that it's absolutely not standard of care at the moment to genetic test these patients for the CYP2C19 SNP. But there's more and more information coming out, and there was just a meta-analysis that came out. Dr. Angiolillo is a senior author in The Lancet, looking at more than 20,000 patients on dual antiplatelet therapy and looking at a combination of genetic testing and also platelet function testing. And there seems to be, at least in the meta-analysis, a very strong association between the genetic testing and clinical events, showing that probably genetic testing and or the platelet function testing will help you kind of tailor your therapy more for each patient and should be associated with improved clinical outcomes. Again, at this point in time, it's not standard of care. And so what we're doing here in the Post in My Clinic is kind of under umbrella of a quality improvement type study, because it's certainly not, it's not that every single patient gets a genetic testing. But I do think probably in the future, it wouldn't surprise me if more and more data come out to kind of support the concept of a personalized, medicine with the genetic testing, especially in this patient population. And if that's the case, it's very possible that we'll be doing it in all patients if it comes out in the guidelines that that's recommended. And that would help us either de-escalate or escalate, patients from one of these antiplatelet medications to another to better kind of suit their needs from a genetic standpoint and also from a cost standpoint, which will help with overall compliance.